Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Good afternoon, everybody. Thank you for inviting me. I'm going to speak about the Oncotype Dx, or the 21 gene recurrence score testing, and how it's changing the management in early breast cancer. First, we have to understand what is Oncotype Dx. Is a 21 gene assay. 16 of these genes are clearly associated with breast cancer, and other 5 were added to normalize the expression for each patient. It was developed by Genomic Health and available since 2004. It predicts outcome in ER positive or PR positive or hormone receptor positive, HER2 negative, early breast cancer. And what is early breast cancer is, again, there's no agreement. Some people will extend early breast cancers for any patient has no metastatic disease. This is how it is reported. We have a value from 0 to 100. The higher the value, the higher the risk, and the higher the value associated with worse outcome. This test was developed on a validation set of tamoxifen, which is the NSBP 20 trial. So always the prediction of risk is based on tamoxifen as the adjuvant hormonal therapy. And this is how you get the result. Like here, we have a sample of 13. Then the result will show the benefit of tamoxifen alone, how much the risk will be with tamoxifen. And then when you add chemo, what is the additional benefit you get from chemotherapy. And based on that, patient can make informed decisions. So now, widely accepted, 10 and less is a low risk, and 26 and more is considered high risk in Oncotype. What is prognostic and predictive marker? Is when high score is after we mean invasive disease-free survival or overall survival. And if it is a low score, then it is a better outcome, and especially these two parameters. What is a predictive marker? Predictive is when an intervention based on an assay, and here we are talking about adjuvant chemotherapy, adding adjuvant results in a better outcome if the assay indicate that. In terms of invasive disease-free survival and or overall survival. But it also means that if you withhold an intervention, and in this case, an adjuvant chemotherapy, it does not result in a worse outcome. So prediction relates to a specific intervention and whether that intervention adds a value in breast cancer outcome. So as I'm going to show you, that Oncotype Dx has become both a prognostic and predictive marker. Some of you say, what do you mean by prediction? And so in terms of the regular daily use, can Oncotype lead to escalation of therapy or de-escalation of therapy? So escalation for a clinician means when you add a therapy, it results in a better outcome. So this justifies a more toxic therapy based on evidence, allows the patient to make informed decision. De-escalating therapy is when you omit chemotherapy in our presentation, it will not result in a worse outcome. And also secondary gains include reducing the cost and reducing toxicity. Now let's look at randomized evidence on Oncotype Dx. This is the famous TAILORx trial that was presented in 2018 in the ASCO meeting, where you have early breast cancer, hormone receptor positive, axillary lymph node negative, T1 to T2, and node negative disease. So they evaluated all these patients for the Oncotype score. Less than 10 were considered low score and went for endocrine therapy alone. More than 26 were considered high score, and all of them were given chemotherapy. The majority of the patient, where you see in this 10,000 patient, which is about 6,000 patient plus, fell in the intermediate risk group. So it was justified to randomize these patients to endocrine therapy alone versus endocrine therapy with chemotherapy. So now we have the TAILORx is talking about early breast cancer, node negative disease, hormone receptor positive, HER2 negative. And we have now 7.5 years of follow-up of this TAILORx trial. You can see, and this is focused on the intermediate risk group. You can see for the whole population, there is no difference in the primary endpoints, which is invasive disease-free survival and distant relapse-free survival by adding chemotherapy. But when we go for subgroups, which were pre-specified, and in this case, young patients who had a score from 16 to 25, did benefit from chemotherapy. As you can see, at 9 years, if their score was 16 to 20, they had 1.6% gain in the primary endpoints, which is here recurrence or distant recurrence-free survival. And if they had a higher oncotype score, like 21 to 25, then even the benefit was more pronounced in these young patients. Although they stratified for pre and postmenopausal, but the data was focused on the young age group. So TAILORx clearly shows a benefit of younger patient with recurrence score in the intermediate group benefit from adding chemotherapy or adjuvant chemotherapy. Then they tried to look at the menopause and the age. You can clearly see that in younger patients who are premenopausal, the benefit is clear. This is exploratory analysis, so we cannot make any firm conclusion from that. It's a theory-generating analysis, but you can see the benefit seems to be consistent in young patients who are premenopausal. What about the postmenopausal? Again, you can see that the benefit seems to be less pronounced if they are postmenopausal and in young age group. So we really don't know. The TAILORx did not answer clearly the question of menopause in terms of benefit from Oncotype Dx testing and the predictive value. Second study is in node positive disease and called responder trial, which is again adjuvant chemotherapy, adjuvant endocrine therapy with or without chemotherapy in hormone receptor positive, HER2 negative, early breast cancer, which have 1 to 3 positive lymph nodes, so N1 disease. And then they clearly use the cutoff of 25 because anyone 26 and above will be considered high risk. So this is a randomized study with more than 5,000 patients, where half of the patients receive endocrine therapy and other half receive chemotherapy, and all of them have a recurrence score of less than 25. And then they had further stratification according to the type of axillary surgery and different levels of recurrence score, as well as menopausal status. And the primary endpoint, as known as very important for breast oncologists, is the invasive disease-free survival, and other endpoints were overall survival. And the chemotherapy were the standard chemotherapy used with is with or without taxane-based therapy. I just want to highlight some of the important aspects of the patient characteristic. If you see the third line here, which is 50 to 59, still 1/3 are premenopausal in this age group. And then the other parameter seems to be balanced. The majority had 1 lymph nodes, with about 10% having 3 lymph nodes. And as we see in our practice, mostly grade 2 disease. And here you can see that there is a T2 to T3, about 42% had more larger tumors than compared to the TAILORx trial. And here we see the invasive disease-free in the overall population. Again, there is The difference is not statistically significant. At 5 years, it was 92.4 versus 91% in the chemotherapy with endocrine therapy versus endocrine therapy alone. But now they start to look at the subgroup analysis, which were pre-planned analysis, and there's a clear difference in the primary endpoint in the premenopausal women where adding chemotherapy resulted in a better invasive disease-free survival. And you can see the value of 5-year is 94% versus 89%. This is an absolute difference of 5.2% with a highly significant p-value with a 50% reduction in the chance of invasive disease recurrence. So very impressive results. So now we have 2 studies which clearly indicate, if we go to the first table, less than 11, this is node negative. The first table is in the node negative. You can see less than 11, no chemotherapy, more than 26. All of them should get chemotherapy. And the study clearly answers less than 50 should get chemotherapy, more than 50 should not have chemotherapy. But again, the pre and menopausal status, I put a big question mark because I believe the premenopausal should receive chemotherapy and the postmenopausal should not receive chemotherapy, but not everybody will agree with that. The second study, which is the summary, you can see now there's only one cutoff, which is 25. And here, the chemotherapy benefit is very clear in premenopausal women, and we should escalate therapy in this group of patients with node-positive disease and one positive disease. But again, what about the age, less than 50? Most of the patients who are less than 50 are premenopausal, so you don't have a problem. But what about those who are less than 50, but more than 50, but still premenopausal? I believe this patient should get chemotherapy based on the result of this study. Just quickly on this study, which had only one arm reported. This is by Professor Nadia Harbeck in the last San Antonio meeting. It's called ADAPT trial, where adjuvant hormonal therapy versus chemotherapy. And here they use a different definition of early breast cancer. You can see clinical stage T1 to T4, clinical node status N0 to N3. These are all, most of them are adjuvant for chemotherapy. And they use 2 parameters, which is the recurrence score and the Ki-67 upfront. And they also gave a group of patients neoadjuvant hormonal therapy, and then they use the expression of Ki-67 after a short course of neoadjuvant hormonal therapy. So this second arm is reported, which is the endocrine therapy alone, and you can see the first group is the low risk, which we all know, recurrence score less than 25, N0 to N1. Most of them will have no chemotherapy, but they also included this other group, which have a Ki-67 response, which becomes less than 10% in the low risk or quote unquote low risk group. And only they got adjuvant hormonal therapy. And these are the group they included. The majority of them in the analyzed group had a short course of neoadjuvant hormonal therapy, which is 1,400 patients. And the other group, which is a standard low-risk patients, also got endocrine therapy. And in this group of what they considered low risk, they could demonstrate that those who are having a favorable response to neoadjuvant hormonal therapy with Ki dropping to less than 10% could do very well with endocrine therapy alone as adjuvant therapy. And here we have a 5-year invasive disease-free survival of 93 or 94 versus 92.6%, which was not statistically significant. So these patients who have a larger tumor and node negative or positive disease, higher recurrence score, if they had a drop in Ki-67, could be behaving as a low-risk disease. And this is they looked at in this particular subgroup. So they didn't report the whole randomized study. This is only this subgroup. It doesn't seem to be different between node negative and node positive disease. They did equally well if they have a low recurrence score or had a higher recurrence score, but a good response to neoadjuvant hormonal therapy. So what is the limitation now of gene testing? One limitation, I believe, is all the prediction of Oncotype is based on tamoxifen as the standard adjuvant hormonal therapy. And we know now that the AI, or in premenopausal lady, woman, ovarian ablation plays a major role in improving the outcomes. So this is one limitation. The other thing, is the benefit of chemotherapy is because of ovarian suppression. Especially, you have seen the data that the premenopausal patients are the one who are really benefiting from the chemotherapy. So is it the ovarian suppression effect, or is it the chemotherapy? And we don't know the answer for that. Most of the chemotherapy benefit based on Oncotype predictions were on CMF and anthracyclines. That's the nature of these studies with their timelines, and did not include addition of other like the taxanes. So I think this is some of the limitation. So I will conclude now. Oncotype Dx is a useful decision-making tool regarding the needs of adjuvant chemotherapy in ER-positive, HER2-negative early breast cancer. High risk, in my opinion, more than 26 should be offered chemotherapy in all subgroups, so that their therapy should be escalated. In node-negative group, women less than 50 should be offered chemotherapy, especially if they have a higher score, and the therapy should be escalated in these women. In node-positive 1 to 3, N1 disease, chemotherapy should be offered in premenopausal women, regardless of the Oncotype results. So this is what I call escalation of therapy, de-escalation of testing. And women with 1 to 3 positive lymph node, recurrence score of 12 to 25, and Ki-67 post-therapy less than 10% may be spared chemotherapy. And I think maybe because I think we need longer follow-up for this trial, and this is a preliminary data. So you could consider de-escalating therapy in this group. No data yet to omit chemotherapy in more than 4 positive lymph node. So you should escalate therapy and de-escalate test. Should not do the test in this subgroup, in my opinion. All the others, which I think are the majority, can have de-escalation of chemotherapy based on the Oncotype testing. Thank you very much.